So we're your presenters today, and as we were discussing this came up as one of the hot topic items that folks were concerned about, and as we've seen with it. And so Cienna has described her situation as secondary, they think, periodic paralysis. And my mom was diagnosed with first primary periodic paralysis, but did not genetically identify. And so now it looks like she's probably in that secondary category as well that she's experienced. And so we'll tell you a little bit about these stories. But along the way, I ended up marrying an ER physician. And so I've spent kind of these, both sides of this thing. I spent about 15, 16 years taking my mom to the hospital, most often about monthly. We'd go and run this route. And then I got to, for the last almost 4 years, hear from my wife what it's like from her perspective when she comes home from the hospital. So maybe we'll tell you a little bit about that. Okay, so here's a recent visit that we took. My mom had a different diagnosis. I told you that she's not genetically identified, but she did get a variant that shows up as kind of related to Gittleman's. And so they've started treating her for that, which has been super effective, by the way. They added salt back to her diet. She'd spent almost 20 years like on a salt-reduced diet, and they reintroduced salt, and she started gaining strength. And so this is another reason why she doesn't have it. So, but as she was changing basically her diet from the last 20 years to a new one, she started one day feeling really bad and weak, and we really hesitate in going to the ER. It's not anybody's favorite place to go, and especially if you have this situation, you don't know what you're going to get. Well, this is the ER doctor benefit, right? So you get to call ahead. And so there are two big providers in the town that I live in. One is the local Trauma One, research university, and that's where she works and is faculty. But her good friend and colleague is the head of the ER department over at the private hospital. And so she just gave a call over and said, hey, are you working today? No. Do you know who's on? This is great, by the way, right? And it's not everybody's experience. And this is kind of the behind the scenes look. And so, great. Well, this is who's coming in. My husband, Mason, great. And he's going to bring in his mom, and this is how she's going to present. And this is what she's going through. Now, this doctor I've met, and she's actually seen my sister, and so we kind of know each other, and she's seen my mom because we've seen this on the medical records right previously going through it. And after hearing how my mom was going to present that day, she said, does she have conversion disorder? So you may have heard that as well. So she's like, no, this is a real situation. So we arrive at the hospital. Here's the protocol, essentially. If you can just have a doctor monitor it, she's just trying to get her labs checked. So we go, everybody's super nice. We go to like kind of an outlier ER, like one of the non-main ones. And then she has a normal panel. She's dehydrated. She's running high glucose. They give her an IV drip. We head home after about 4 hours, and she immediately wastes all these IV fluids. We got bed rest and all that. A pretty good visit overall, right? And so.
And now it's your turn, because we know that most of you have been to the ER too. So you're going to take 2 minutes to tell your neighbor about your ER experience, either as a patient or as a caregiver, and then you're going to switch. So you're going to listen to your neighbor for 2 minutes about their ER experience. You're going to get 5 minutes to do this, and we're going to be back.
Okay, go.
All right, everyone, back up here. So we've heard about your perspective. We've all talked about it. You heard your neighbors, you talked about yours, but what is the ER perspective? What is it like working in the ER, having all these people come in? You've got 15 to 30 new patients per doctor for each 8-hour shift.
Yep, and in the waiting room, I've talked to my wife about this. Ever since COVID, they have run so heavy. She'll have anywhere between 20 on a light day or up to 50 plus in the waiting room. And some patients are waiting 18 to 24 hours plus to get in. So you can imagine how everybody arrives when they're there, right? You've gone for an emergency and you've waited a full day in the emergency waiting room.
Yeah, and on top of that, you're managing your attendings, your residents, your interns, nurses, EMTs, your specialists, and security.
And what I hear oftentimes are about the politics, the personalities, and the priorities of the ER. And there are a lot. And it's not just downline like interpersonal stuff, and it's not just between doctor-patient. There's also a whole level of administration that you're dealing with and everything else. Yep. I got a amen from the audience. All right.
On top of that, you've got patients coming in with FND and PNES. You don't know them. There's a lot going on. What is happening?
Yep, and we'll talk about that a little bit. And then you've got existing patients, transfers, traumas, fast-track cases. If you're working, where my wife works, there's 3 cores, essentially. And if you pick, there was one of them that has both I believe the psychiatry patients, right, that are coming in, the psych patients, and they're also dealing with the waiting room. And so they also have the transfer calls. So imagine every other hospital in the region that's sending you their patients, right? And you need an attending doctor to answer the phone and receive those. And so that's in between all of the other stuff that you've been doing. And then finally,
You've got EKGs to sign. Every 10 to 15 minutes you have one coming in, and there's a time limit. You got to sign them fast.
yeah, so she has a 15-minute window where by their own internal regulation, they have to have an EKG read and signed off on. So everyone that comes in and gets an EKG, that stops her work. She has to evaluate it and to do it. All right, so that's that. And then how about the education that they've shown up with? Obviously, they've been to school for a really long time, but not for this. So here's what they know about periodic paralysis from medical school, and this may have changed from the time she went in, but I doubt it's very much different. From medical school, hey, there's this really rare thing. You'll probably never see it in your entire career, but if you do, it's going to present as a young Asian male who has a thyroid problem, right? And I haven't seen that patient here yet. Cienna?
Yeah, and then you keep doing your continuing education, and you go to EMRAP before, and again, it's your young Asian male with a thyroid disorder.
Yes, and the treatment, they say, is they may need to eat a banana. I swear, I was listening, she does these 30-minute podcasts as part of her continuing ed, and EMRAP is like the #1, I think, for emergency department folks. And I was listening to this case study literally as we were driving down the highway, and I was like, this is the most insane thing I've ever heard. I mean, this will literally keep a person in the hospital. And that was the status quo. So she wrote EMRAP. And whether or not they changed it for her or not, I don't know, but it was after this conference that she went to 2 years ago. And now it actually has a write-up on hypo and hyper. And so you've got a little bit better situation, but that's if they've happened to listen to that episode, right? Or if they consult it, which they often will at the time. So you're up against that. And then the good news
Is you're going in for treatment. So what's the outcome? Well, you've got muscle weakness. They're going to put you on a stroke alert. They're going to work you up for a stroke. You're going to get a head CT. They might think you have hemiplegic migraines.
Yep, and that's after they send you to neuro, right? So if they don't know what you're coming in as, then this is, she said, 99% of the time, they're going to stroke alert you, and they'll give you a full head CT, probably with contrast. They'll consult neuro. Neuro may give you hemiplegic migraines. If they don't like that idea, they may send you over to column right, and that's where they put you into FND, which is the nice way of saying conversion disorder. Or they may say, we just don't know what they have, right? And so that's kind of the pattern, but here's some good news, and that's what we're trying to do. Well, before we get to the good news, quick note about what FND is. So if you want to take the first one, I'll tell the example.
Okay. Functional neurological disorder is what FND stands for, also known as conversion disorder. It's defined as a neurological symptoms like weakness or paralysis, which are real and involuntary, but not caused by a known neurological disease. FND can account up for 10% of stroke mimics and 15% of neurology presentations in the ER.
Yeah, and just anecdotally, the rate is extraordinarily high in and of itself, right? And this is like from JAMA and like well-known, well-researched things. When you show up, there's an extraordinary high percentage of folks that fit this category clinically that come in through the ER. But the anecdotal part is that they think it's happening like all the time because the cases are so sort of top of mind for them when they see them, and it takes so much of their time that they've got their own version of PTSD. So here's an example of someone who came in with a thing they call a PNES, which is like a epileptic seizure presentation, but it doesn't have a rooting in a medical cause. So she had a patient who stated their history of had multiple strokes. They had overt physical symptoms, so a droopy face, one-sided weakness. She does a full stroke workup on them. It comes back negative. They're referred to neuro, negative. They're referred to psych. The doctor, returns to find the patient in another patient's room, right? So she's coming back now with another patient's room, and they're talking, no more symptoms. And then she comes to find out, she's like, hey, what's going on? Well, this is my friend. We come into the ER together. So this person is being also worked up at the same time. I had no idea this was going on. I know it was never the case when we went in, right, for us. I mean, it was always very serious, and I know in this room it's always very serious. But this is the other side of it. She deals with prisoners from the local prison who sometimes want out of prison to go, and so they will self-harm. She deals with folks that are homeless, that sometimes want to get in off the street, which is totally understandable. And so there's a lot of cases that come in that aren't you, but that's what they're up against. So it's a trigger for doctors because they're hard to distinguish from the folks who are just acting up, the F&D folks. And then for patients, once you get this kind of label, it's really tough, right? If you've got to overcome it. So finally to the good news part of the slides.
Things that help. So what can you do to help get the care you need when you're in the ER? And the first one of those is a simple presentation. So instead of bringing in your big binder with all of your results, your MRI discs, all of that, just have a one-sheeter that you're bringing into the ER. Just simple. Just all the facts. What is periodic paralysis? Why do you have it?
Yeah, and I will say this, when we were kind of discussing this, and she couldn't be here because she had a shift, and then she's on call tomorrow morning. But she said, look, our job is honestly just to get you stable and get you somewhere. We're not going to be able to solve your problems. And so a lot of times I know just from personal experience showing up with my mom, she didn't have a lot of exposure or access to doctors. And so that was kind of her shot to sort of share all the information that had happened since the last time she saw a medical provider. Well, the ER is often not the place that's going to be the most receptive for that, just because of what you've heard. Shareable tools, we're going to share some of those with you. You've got some actually, and we're about to give you some more. And then finally,
stay professional in tone and attitude when you're talking to them. Convey yourself like Ross was talking about earlier. Have those numbers, be able to describe it, and just stay positive when you're talking to them.
And I'd say if it's not you, right, because sometimes that's not going to be you in that situation if you're the patient, but your caregiver could do that, right, on your behalf. And that's something I would just say really intentionally. It's can you have a plan going forward where you've agreed ahead of time that either you're going to be in a position to share in a kind of a more neutral tone, or can your caregiver do it to assure that you have the best care that you possibly can get?
Yeah, clear communication. So this can be from you, from your caregiver. So you're going to start out with that simple presentation. You're going to say something like, I have periodic paralysis, and I'm experiencing an acute TAC. I have a protocol sheet from my neurologist that explains everything you need to know. So the whole goal of that is using it to be your own best advocate when you're communicating. And also, like we were talking about, keeping in mind, if it's been a longer wait, it's because they're slammed at the ER back there too. It's not because they just want to keep you out there waiting.
Yeah, and sometimes they come in hot. I mean, I've probably the 30 or 40 ER docs that I've met in my very small town because of going through 20 years with my mom. You get a range of personality types, right? And so just, understand somebody's got to de-escalate it, right? Somebody's got to be the grown-up. Shareable tools. Here's a simple one-page outline. This condition is rare. This sheet will help us find a clear treatment path. And so the idea of this is a partnering strategy versus a demanding one. You're there to help them do their job efficiently. I will tell you that generationally, it seems like, quite frankly, younger in their career, emergency docs that we've gone into are much more open to the idea of if you come in with a very clear idea of what's happening and state that in a pretty rational way, they're just like, okay, and what do you want to do? What's usually good for you? And they seem very open to this versus kind of trying to say, well, I'm the medical provider here. I'll be giving you the medical opinion. And then finally.
Yeah, I'd have to agree with that. And then coming in at that point with that professional tone, just mentioning the most likely test that you're going to need, a rapid blood test for potassium, an EKG, and then what's that necessary expected part of the protocol that's going to come next.
Yeah, and please hear that this is not because you don't have the right to show up however you feel like when you show up. It's just trying to give you the best tools to get the best condition, right? Like coming out of that. And so here are some tools that we identified and that actually are, well, the next slide is we're going to get available to you.
Yeah. So these shareable tools are first ones to get ready. Prepare some simple shareable tools. You said that just now, so that's great. You can have a medical alert ID. So that's a really helpful one. Jared from our board has made a wonderful video on YouTube. It's on our PPA YouTube channel. It's all about medical alert bracelets. We've got advice from Dr. Har about what needs to be on there. And just wearing that's going to help you out.
Yeah, and we've heard from a number of sources about how valuable that is. And my wife is after me to get one done, right? Because it's genetic and it runs in our family. I haven't done that. But she said, you don't know how valuable this is, and if I'm not around, you really want that. So I do recommend that. The note from neurology, when we asked her just cold, like, hey, what would be helpful to just come in for a patient like my mom? What would be great for you? She said, if you could just get a note from your neurologist that validates what you're saying, like that will change the whole disposition of the visit. They'll take a look at that. They'll be like, okay, we may or may not know what this is, but now you've got kind of a level of credence that you didn't have when you were coming in cold.
Yeah, and this one's completely unbiased, of course. The PPA website, if you go on there under the PPP 101 tab, Connor says it's great, so take her word for it.
She did. She actually went online. She was trying to figure it out, and she went through that PP 101. She saw, I think it was Dr. Cannon's actually video, and she said this would actually be a super help. If I'm not familiar with it at all, watching this, I would feel like, okay, I have a baseline. I know at least, how to navigate a little bit. And then some of these things.
Yeah, so putting that together is a lot of work, right? So we've kind of helped you out with that, and so is the PPI. We have the honor of announcing that the PPI now has a hospital emergency care guide on their website for hypokalemic periodic paralysis attacks. It's a nice one-pager, like we were talking about, that you can print out. It was made with ER doctors. You can bring it in with you, and it will help guide you through that process and help guide them through that process. Then, I'll give it to Mason.
Nope, go
Oh, you
ahead.
want me to take
Yeah.
that one too? Okay. So if you checked in today, you have a handy-dandy little tote bag, and inside of that is this card that says, I have periodic paralysis. You're going to write your name on it, your type of PP, and your emergency contact. And we recommend probably keeping it with your ID. So if you're ever in an emergency or in an accident, when they pull your ID out of your wallet, they're going to see this card. And on the back, they can scan the little QR code, and it's going to take them right to Dr. Har's quick reference guides. So that's going to be an incredible resource. If you're not able to advocate for yourself in that situation, this card can.
Yep, and I think that may be our last slide. Nope, here's the last slide. All right, so you did your 2-minute back and forth. Take 2 minutes now and think about what your new plan might be, right? Is there anything that you heard today that you might like to add to kind of the protocol that you normally go in on? And so take a couple minutes and then take a minute to share it with the neighbor that you shared with before and have them share theirs. Does that make sense? Or we would just want you to leave with a little bit of a plan. All right, gang, we'll get you to pause your conversation for just a second. And we've had a question up here. You saw it was a hypo ER sort of one sheet. The question was, where's the hyper? That's a fair question, right? And they are developing it. It isn't out yet. This one was done midnight. So, you know, I don't, maybe later today. I think it'll take a little bit longer.
It's going to take you to all of them. Dr. Har is going to talk about tomorrow, but he's got some exciting news on 7 different quick reference guides that are going to be up there.
And a very exhaustive thing, so really good stuff. I was asked.
Yes, hot off the press.
Hot off
Just
the press.
for you.
Well, had to be okayed. All right, so I asked Connor, I said, she got to see the last couple of minutes of this, and she said it was good. I said, any words of wisdom for anybody? So this is the ER perspective. She said, I just don't want people to be discouraged. You know, the ER is a rough place on both sides. So hang in there, right? You know, and you do your best, they're going to do their best, and we're going to get through it together, okay?
Yeah, so now we're going to take a break, and we'll be back in 30 minutes.
All right, so nice long break.